I am David Feldstein. I'm a general internist and researcher at UW. I'm lucky enough to have on the panel here today with me Irma Cintron as our patient representative, and John Hawkins, I apologize, as our clinician, and he is at UW in Sun Prairie in a family practice clinic. So I'm going to start by telling you a little bit about diabetes and chronic kidney disease. You see, we get to get two diseases. We're so good. And then I'll let Irma speak about her experience. So first, starting with what is diabetes. Diabetes is diagnosed when your blood sugars are too high. So there are two main reasons for this. Either your body doesn't make enough insulin, or in some cases any insulin, or your body doesn't respond appropriately to insulin, so it's resistant. Here we have the type 1 and type 2 terminology. More commonly now we hear about insulin-dependent and non-insulin-dependent diabetes. They're somewhat similar. But the idea is that in patients who require insulin, they're the ones who are not making enough insulin. And then in some of our non-insulin requiring diabetics, those are ones who have resistance or other metabolic problems. The symptoms here, this is a chronic disease. In fact, the symptoms for the non-insulin dependent or type 2 is often nothing. So they don't have any symptoms for a very long time, and that's one of the problems. They can go quite a long time before they're diagnosed. In type 1, they usually present quite quickly with frequent urination, extreme thirst or hunger, and often present to the emergency room even. So the real problem with diabetes is not that initial symptoms, but it's what happens over time, again, as a chronic disease. So this can lead to blindness from retinopathy. It can lead to decreased perfusion or decreased blood flow to your extremities, decreased sensation in your extremities as well. So that can lead to infections, including gangrene. Heart disease is a major problem in patients with diabetes, as well as kidney disease, which fits in with our other topic. What is the burden? Diabetes is a huge burden, and one of the issues is that there's just an explosion of type 2 or non-insulin dependent diabetes in this country. You can see how many people currently have diabetes, almost 30 million, and then a very significant amount with pre-diabetes. Very high on our leading causes of death, and an incredible amount of money spent on diabetes care each year, not to mention missed work and school days. Okay, so that's diabetes. Let's move on to chronic kidney disease. So chronic, as it sounds like, is a gradual loss over time. So it's a gradual worsening of your kidney function. Your kidney filters out some of the toxins from your body. It's really a giant filter. And what happens over time, that filtering ability decreases. Type 2 diabetes or non-insulin dependent diabetes is the #1 cause of chronic kidney disease, and that's because we have such a large population of diabetics. Again, this is long-term, and the initial symptoms are nothing. So you can go years and years and years and never know you have chronic kidney disease. In fact, these symptoms you get are very late in the game, and we'll talk about the stages in a minute. But late in the game, you can get fluid overload, you can get all sorts of metabolic problems as well, and the biggest issue is that it dramatically increases your risk of heart disease and heart attacks. And most people will die from heart disease, not from their chronic kidney disease. Chronic kidney disease is broken down into different stages. These are the 5 stages. Stage 1 and 2 we don't talk about too much. That's where the kidney's actually filtering like it should be, but there's some other either structural abnormality or protein leakage. But what we really focus is on stage 3 through 5. Stage 3A being mild, 3B moderate decrease in kidney function. Starting at stage 3B is where you start to see some of those metabolic problems. Stage 4, which is now severely reduced kidney function, and stage 5 is severe decrease in your kidney function, leading to end-stage renal disease, and that requires dialysis or transplant. The burden, again, is huge from chronic kidney disease. This is also increasing, 20 million people with chronic kidney disease, and you can see in diabetics and people with high blood pressure, very high rates. And the combination of diabetes and hypertension increases your risk of going on to end-stage renal disease. Certain groups here, African Americans and Hispanics, are more likely to go on to end-stage renal disease, and we don't necessarily understand why that is. And again, a high leading cause of death with a very high cost burden in the US. So now, I'll turn it over to Irma, and she can give us her perspective.
Thank you. Hi. Oh, that's loud. Hi, my name's Irma Cintron, and I come from Waukesha. I was born and raised in Texas. After I graduated high school, I went on to college. Graduated college, came back home, got married, and then moved to Waukesha. Found a job, which I thought was a perfect job, financial advisor for an orthopedic group. Of course, there were so many goodies there. You ate all the time. Cake, parties were an excuse to have a party. So I went for a physical, and my doctor says, you're pre-diabetic. You're on the verge of having high blood pressure. Your cholesterol's high. I thought, oh, well, you know, I'm not a diabetic yet. I don't have that much high cholesterol or high blood pressure, so didn't do a thing about it. So then went back to work, bad habits again, overeating, no exercise. Then I lost my job. Due to downsizing, I lost my job, and I lost my income, lost my insurance. So what was I supposed to do now? You know, the husband was not around anymore. So I ate some more. I binged eat. I gained weight. Then that's where St. Joe's Free Clinic and Cindy from the Kidney Foundation came in. They gave me the tools that I needed. They took care of me. They visited me. They made sure that I was doing everything right. They set up these pre-diabetic clinics for me. I went to those. They taught me how to cook, hands-on. So I took all the advice that they gave me. And I thought, you know, I've got 2 kids. They were grown up, a granddaughter. And my son comes to me and he says to me, Mom, please take care of yourself. He says, I want you to be around for me, for my grandchildren, you know, me, be around for my grandchildren, which she doesn't have yet, but I have a granddaughter, and I want to be around for her. I want to be around for my kids, my future grandkids, and I had to do something. So I had to, these challenges were out there for me. I had no income. You know, what was I going to do? I was like, I need help. You know, so I went again to St. Joe's, and I took it seriously. And I should have done this in the first place, because my dad had high blood pressure, didn't do what he was supposed to do. So he ended up in a coma for 9 years, till the day he died. My grandfather was a diabetic, didn't take care of himself, so he passed away. So I should have taken care of that when my doctor in the beginning had said, you know, take care of yourself, do this, do that, because you're going to end up a diabetic and all these health problems. Well, it was a rude awakening for me when I found out, you know, I'm going to be a diabetic. I'm going to have my limbs cut off. It just kind of dawned on me, okay, I need to do something. I need to take care of myself, which I started doing. I joined the gym, lost 40 pounds. Because of St. Joe's and Cindy at the Kidney Foundation, who gave me all the tools, I was able to eat the right foods, measure, be sensible about everything that I did. Was dedicated to losing the weight and eating right, portion control, learning how to cook. And so my son comes back to me, he says, Mom, I'm really proud of you. He says, because you're doing everything you're supposed to do. And at your age, some people would probably just give up, you know, because I just turned 64 yesterday. And he says, so people at 64, he thought I should be, you know, some people sit on the rocking chair. I said, no, I'm not going to do that, you know. So I joined the gym and I work out, and I've lost all that weight. And I'm so grateful for Rosa at St. Joe's Free Clinic and for Cindy at the foundation, Kidney Foundation. They were there for me. They give me the tools to do, you know, and get better, get healthy, and they helped me along the way. So I think that's the most important thing, that there's people out there that are willing to help you. And that's where they came in, and they've been such a blessing to me. I just can't say enough about them because, they have been there for me, and I'm healthy now. I'm not a pre-diabetic. My blood pressure is under control, and my cholesterol is under control. And like I said, I work out, and I plan to be around for a long time. So I guess that's my life now. So, and I do, like I go to the gym, I do crafts, I do jewelry, I read, so I'm retired now. I had to retire, I couldn't find a job. So, you have a job for me? No. So, thank you.
Well, it's tough to follow that up. That was a great story here. I get to kind of contrast that with, from the clinician's perspective, the challenges of chronic disease management. We're just there, as we see it, to help patients manage their chronic disease, and kind of what I'll be talking about is kind of just the nuts and bolts of kind of our day-to-day struggles with that, and I hope that will launch further discussions. Some of the themes have already kind of been hit on, but I wanted to just go over, I tried to break it up into a few categories here. The first being task completion, and I'll go into each of these more, assessing a patient's specific care, and then having a say in the process as related to chronic disease management. When I talk about task completion, we're trying to re-examine of really how can we take care of chronic disease management. Obviously, it's good to see that there's a lot of smart people trying to put, thought into that. Just because just how we've done it for so long, obviously, I don't think has been the best way to do it. As I picture it now, I'll have a patient show up at clinic, and they're there for whatever reason. Maybe it's for follow-up of blood pressure, or for chronic kidney disease or diabetes, and it's often kind of a struggle of what can we get done today while the patient's here. We've gotten very good at trying to address patients' needs. We try to prioritize things. We teach med students, hey, set up priorities for the visit. Sometimes that goes well for a visit, sometimes not as well. And so we're maybe talking about one thing. I might be sitting on the computer entering orders for labs are due, kind of scrambling through and doing all this, but I guess the part I struggle with is kind of the frustration. Am I missing something more important that we should be doing today versus, for another day? Other things as we work through that is, well, how can we make this more efficient? And we've started, and I'm sure it varies clinic to clinic, of pre-visit planning and working on what we call workbench, where we have, let's say, all our patients with diabetes listed for, that I'm their primary care physician, and we'll go through that, and when we have, we either have a set schedule or when we have time, we'll work on saying, okay, this patient's due for this lab, they're due for this one, let's get them in. Ideally, we have all these labs done by the time they come see me for their clinic visit. That works well sometimes, sometimes it doesn't work as well. And again, we're trying to scramble. It's done somewhat consistently, but not 100% of the time. So again, while I'm sitting in at a visit with a patient where we might be talking about a complete different subject, I'm looking through their labs to see, are they up to date on all this? Is there any reminders popping up that say it? Sometimes there is, sometimes there's not. I know if their blood pressure is too high, but I don't necessarily know if their microalbumin's been done, for example. Kind of the next step that we've taken in my organization with UW Health is we're using more care coordination, which I don't know if I should say it, but as I've described it, I think the concept of it is fantastic. The reality of it is, as we're trying to implement it, we have these wonderful RNs doing care coordination and providing an invaluable service, but they're often struggling to find the time to do that specifically versus all the other things we want them to do at clinic as they take care of patients. And we find them getting pulled 6 different ways, which can lead to frustration on their part. The patients are trying to connect back with the nurses, and as I said, when it does happen, it's wonderful. I've had with our care coordinators at our clinic, I've had real breakthroughs with patients that I haven't been able to kind of budge for years and years, and it's it's just a matter of having enough people and enough time to do all these things. So that's kind of the first area here, which kind of goes into the next one. As we're working with patients and trying to assess where they are, I've become more acutely aware of we don't always really do a good job of assessing a patient-specific care. Ideally, the patients coming to our clinic, we've cared for them for years and years. In reality, I have patients that are bouncing back and forth from my clinic to another one in town, through a separate healthcare system due to changes in their work insurance. And so I might see them for 2 years, they go to another system for another year, come back, and in between, as they come back to me, I try to see, simple things of just figuring out, have they been on an ACE inhibitor, which ones have they been on, which ones have they had reactions to. I kind of always feel a little not quite right as patients looking at me like, how do you not know this about me? It's all in the computer, and I hear that every day of, well, I had my records sent over, I signed all the forms I was supposed to send over, and still we're kind of looking through scanned copies of records, and I feel it's one of those opportunities where we're often missing, providing the best care, and then we're kind of trying to backtrack of making sure they're on all the things they're supposed to be on or having everything done. And again, I'll often go through a whole plan and say, okay, this is what we're going to start you with. They're like, oh, I was on that 3 years ago. I threw up from that. So then I'm kind of, you're back to square one. So it's kind of I don't always feel I build patient confidence at moments like that when they think we should know these things, but obviously we don't. And then, of course, as we go through the different care plans, whether it's for chronic kidney disease or for diabetes or for whatever other chronic disease we may be dealing with, again, what the themes that have been brought up today is their perceptions of what's best for their health. I can talk about guidelines and what they should be on, but obviously they're going to be strongly influenced by what happened to their sister-in-law that was on this medication. Commercials that they see on TV, and as Dr. McBride was mentioning, of just explaining to what patients have seen or heard or believe what they've read on the internet. And it's gotten to the point where I've had patients that have stopped their blood pressure med, their ACE inhibitor, because they received a letter from their insurance company that said they need to have this testing done if they want to remain on this medication. We had done the testing. They weren't aware we had done, the kidney testing. Unfortunately, months had gone by where they weren't on this medication. Unfortunately, also they didn't contact us, to say, hey, I'm going to stop this medication, or at least to discuss it with us. But these things are happening, and again, it always kind of makes me wonder, how are we going about this? Obviously, there's many opportunities for improvement. And as that brings us to kind of our last theme here, is us clinicians, physicians, whoever's helping provide this care, having more of a say in this process. I work for UW Health. It's I think, a very great organization, but it's also a very big organization. So for what may work for our clinic may not work for the next clinic. There's obviously going to be common themes, but with primary care redesign and other protocols that have come out, it's made it very hard to always do the best process at our clinic, or not necessarily have the support to do this. I don't want to sound too negative, but it's something we're kind of putting a new work into, of trying to figure out how can we best do team-based care. We've used the phrase, as I'm at a committee for that, we don't quite know what that means right now, and we're going to continue to investigate what that means and hopefully come up with some new solutions for that. As the topics were chronic kidney disease versus diabetes, for me personally, it works out well, or it was kind of a big contrast. We had done the chronic kidney disease project through REN a few years ago, and we were all excited, and we were targeting and finding patients with chronic kidney disease, educating them, filling in their problem list, listing, getting them off their NSAIDs, and we were having trouble populating that to our workbench. We had to get monthly emails, essentially, of those lists because it wasn't readily apparent through Epic. And as we got assigned to doing other tasks, all of a sudden we didn't have the time to work on chronic kidney disease, where diabetes, we're constantly reminded of how well or not well we're doing on checking A1Cs, checking microalbumins. Our kidney testing numbers are still much better than all our other factors. I think my personal thought is because of what we were doing previously for chronic kidney disease, but it's just we're kind of having to bow down to what the organization feels is best, when obviously we could probably do these things together quite well, but it's not on their priority as it is now. And again, that makes us frustrated, as we've had put a lot of time and effort and had excellent staff working on that in the past, and now it's almost like not wasted time, but we're not able to build on that like we did in the past. And again, as that gets applied across the entire organization, and with that, looking at staffing models and how many people do we really need to take care of these patients and along with their diseases, and how to do that most efficiently. And so that's things that can be kind of the roadblocks to doing the best here. So, and my last slide was just other factors or thoughts I had while sitting here, but a lot of it's been hit on already, but those are things that we can come up during the question part. So, thank you.
Okay, I'm back. So I have no financial disclosures. That came up earlier. I think that's important to say. But I do have another disclosure, which is I am not a kidney disease expert, but I am an expert in implementation research, and that's what I do. I happen to have done research in chronic kidney disease, but the main thing is implementation. How do we get things that we know work into care? I will focus mainly on chronic kidney disease because that's where I've done research, but you'll see that virtually all of this can cross over. So I'll start out talking a little bit about the gaps currently in chronic kidney disease care, and they're pretty big. And then the three opportunities I'm going to talk about are treatment based on, I should say, intensity of care in terms of chronic kidney disease, clinical decision support, and electronic health records in caring for patients with chronic kidney disease, and shared decision making. So what do we know about our gaps in care? Well, we know that actually many of our CKD patients aren't even aware that they have CKD. So remember the stages, stage 1 and 2 we won't worry about too much, but stage 3, when you have moderate or some mild to moderate reduction in your filtration rate, you can see 20% of the patients don't even know that they have the disease. And we found this out in one of our studies when we sent out letters trying to enroll people, and they said, what do you mean I have chronic kidney disease? Yet it had been in their health record multiple times, which is how we chose it. We had to change how we enrolled our patients. And even in stage 4 and 5, we're getting into severe chronic kidney disease, there's 10% there that don't even know they have any disease at all. And you can see how low the rates of treatment and control are. Well, even if they do know they have disease, most of them are not receiving what we would consider guideline-based or recommended care. So these are a number of measures that are recommended by KDIGO, which is kind of the big international group that gives us guidelines for chronic kidney disease. And if you look just over on the right-hand side here of the total, so in each of these categories, we're talking about, only about, so these are not receiving care. So, somewhere between 40 and 50% are not receiving the care that they should be getting. So that's a huge number. Even in our stage 5, huge numbers of people not getting the care they should be getting. So we have a long way to go, and that's part of why I like implementation research. There's lots of room for improvement. There are some studies, well, what do we know about how primary care clinicians feel about treating their patients with chronic kidney disease? There are 3 studies only. 2 of them are interview studies, one from upstate New York, another from the UK, and then we did a focus group study with Ren's help, with clinicians from throughout Wisconsin. And some of the lessons we learned were, so these are some of the barriers, were guidelines in general. So the guidelines, first off, many people didn't know that they existed, so that was a major problem. We could do some education there. But the ones that did, they didn't trust the guidelines. They felt that they were done by experts. They weren't done by people in primary care. And they also felt that they weren't flexible. So it was kind of cookie cutter medicine. I'm supposed to do this, but it doesn't take into account what else is going on with my patient. And as we know, our patients are all very complicated. Problems with the system. So this is a major problem. Our system was originally designed for acute care, not chronic care. Now we're trying to morph it into chronic care, but originally this was for acute episodic care. That doesn't work so well when you're trying to follow someone over time. The lack of decision support tools, how you distribute the work within the team. These are all themes we've been hearing over and over again. And this one we haven't heard so much, this specialty versus primary care issue. So now they're having multiple physicians. Who's taking care of what? How should that interaction work? And then access to nephrology. Some of our Clinicians told about their patients that basically refused to see a nephrologist even though they wanted them to see one because it was a 50 or 60 mile drive and they just weren't going to do it. Why can't you just take care of me? There were issues or barriers from a provider standpoint. Many were uncomfortable or unsure what to do in these patients with this mild kidney disease, so stage 3 kidney disease. What do we tell them about that? What should we do about it? They didn't know when they should be referring to nephrologists, so which patients should see a nephrologist. They felt like they would send some patients and the nephrologist would just send them back saying we don't need to do anything, and others they would hang on to and they wouldn't want the nephrologist to hang on to, so they weren't sure when to do this. And these issues came up in terms of society, so mainly this lack of recognition of the importance of chronic kidney disease. So we heard it's not necessarily a priority in my organization, but from a public standpoint, most of the public doesn't know what chronic kidney disease is. Yet if you ask them about breast cancer, everyone sees the pink ribbons. Now, I guess this month everyone in the NFL is wearing pink, so it's pretty obvious, but yet they don't know about chronic kidney disease. So what are some of the opportunities or controversies? One is this issue of stage 3 chronic kidney disease in the elderly. And these are two opinion pieces published in JAMA. I can't remember when I came up with these slides. It was right when we did the slides, I think a month or two ago. And the issue is almost everyone as they get older, which you'll see here, develops chronic kidney disease. So if you follow people, if you look at the bottom row there, 85-year-olds, so 80% of people who are age 85 have chronic kidney disease by that definition. Well, that seems like a problem that 80% of our patients would have it, and 60% of that is stage 3, which is mild disease. So what's it mean to have mild disease when you're 85 years old? Should we do anything about that? Should we even label you? What effect is that going to have? So we do know that there's increased mortality with increasing EGFR. So that's real, that's an issue. We know that the difference changes a little as you get older, so it's not as much of a relative increase in mortality. But we have no evidence to know whether treating these patients is going to have an impact ultimately on their life, or are we just going to label them with the disease and treat them and not really have any benefits. So what are some potential questions around this idea of diagnosing elderly and intensive treatment? So one is, should the diagnosis of CKD change in the elderly? So if you have something where 80% of the population, once they're 85, has a disease, how do we address that? Are we just basically labeling everyone with this disease? What are the harms? So no one's looked at that. What happens if we do diagnose them with CKD? What are the benefits of doing that, and what are the harms? Now, we know in younger people we can prevent the progression, and that's really what treating chronic kidney disease is all about. How do you prevent the progression to end stage and dialysis? But if you're 85, are you going to progress? And should we change our guideline recommendations? So right now, we're supposed to treat our 85-year-olds the same way that we treat our 65-year-olds. That doesn't seem to make sense to me, but we don't really have age-related recommendations right now. So let me move on to the second opportunity here, which is the role of clinical decision support, or the EHR, in improving chronic kidney disease care. What do we know? We know that registries alone don't necessarily seem to work. And the issue with that is it's great to keep track of everyone who has chronic kidney disease, but if you don't have a way of accessing it when you need it, and you don't have someone who is actively going through and contacting those patients, it's not enough. Integrated solutions have worked, where they have a combination of some of these things. So case managers, computer decision support, academic detailing with audit and feedback. So those have improved the process measures. But in fact, we really don't know what kind of implementation strategies improve real patient outcomes. So some of the questions here are, what is the best design? What clinical decision support things do we need? Hopefully, you guys can help us out with that. And then how do you best incorporate that into your clinic? That's a major problem. It has to fit into your workflow. So who's going to take care of what? How is that going to work? This may help us get an idea there. So I don't know if you're familiar with e-consults, where a primary clinician can contact a specialist and they can basically talk back and forth. So if you have a simple question, they can help answer it. You may not have to send the patient, so certainly can have an impact on the patient. But how can that fit in? And again, that can be through the electronic health record. So the final opportunity I'm going to talk about is shared decision-making in CKD diagnosis and treatment. So I put this in somewhat because I really think shared decision-making is important, and I've done some research in the area, and so this fits for every disease. There's nothing specific here to chronic kidney disease, so another disclaimer, I guess. But what is shared decision-making? We've heard it kind of battered around a little bit here, and it really combines three components. So information exchange. The physician has to inform the patient. And what do they inform the patient about? The different treatment options, the benefits and the risks of each option. So you need to know how to appropriately tell your patient what are the risks, what are the benefits for these options I'm presenting. The patient, then, on the other hand, has to provide information back to the provider. So the patient has to give the clinician information about their own values and preferences, lifestyles and beliefs, and what they know about the about the illness and its treatment. Then there's a deliberation period where you kind of get together and discuss it and ultimately decide on a treatment together. So that's really what shared decision-making is. Sometimes it falls more in the patient education than the true shared decision-making. So what do we know about presenting? This came up, I can't remember who mentioned it earlier, but what do we know about how we present the risks and benefits to patients? So we actually did a systematic review, I guess it was published last summer, on how to present risks to patients. And there are some things we know. We know we should avoid the use of qualitative descriptors. And those are things like saying, well, you're at high risk of developing, or, X. So the problem is that high risk means different things to different people. Even when, and I love to do this, when we take a room of clinicians and say, what is high risk for, death to you, the high risk and the low risk always overlap. So it's interesting. But you can imagine to a patient, high risk, they tend to think really high risk, 80, 90%. As a clinician, we may think high risk is 15, 10%. On mortality, we might think that's 2%. So not using those qualitative descriptors. Using event rates or natural frequency. So this gets some at literacy, so health literacy, but numeracy as well. So rather than saying, well, 10% of people, you say basically 10 out of 100, or in this case, 1 in 10, always using the same denominators when you describe that. So you would say, 10 out of 100 patients will have an improvement in their symptoms, and 1 out of 100 patients will have a worsening of their symptoms. So that way they can help at least understand. You can't do shared decision-making until you understand what you're actually deciding about. Expressing benefits in absolute terms, we won't get into that too much, but also adding graphical representation, so bar charts or icon arrays that can help you not only see numerically, but also see visually what's going on. How do we determine the quality of a decision? So in research, they use something called the decisional conflict scale. And decisional conflict is basically what it says. So how conflicted are you about the decision? How unsure are you? How uncomfortable does it make you? And you can see we have a few things here that we know increases decisional conflict. So when people are uninformed, when they're not sure of what their own personal values are, that's not always an easy thing to decide. And then when they feel they're not supported in making a choice, or that they're pressured to choose. What we've shown is that higher conflict scores correlate with people either delaying their vaccinations or delaying their mammograms, but that's really about it. So we don't know too much about this. So how can we figure out if someone has made the right choice? This is the decisional conflict scale. You're obviously not going to use that in clinical practice, but what can we use in clinical practice so we can be sure at least that our patient made the right decision for them, not for our metric, not for us, but for them. So shared decision-making, some questions here. So what is the best measure to determine if a patient had the correct decision? That's certainly something that this group could look at. At what point in the process, or how should we use clinical decision aids? So clinical decision aids, oftentimes patients will work on their own and then bring back to the clinician. Where should those fit into the process? What are the best ones to use? And also, how will true shared decision-making impact quality of care metric performance? So probably everyone in this room has complained about metrics at some point. I complain about metrics all the time. But so we're told we should go to shared decision-making, but we have to meet all these metrics. So guess what? When we leave it up to the patients, maybe for borderline hypertension, they don't want to be treated because in fact, the benefit may not be enough to be worth the harm for them, or maybe adding on that third or fourth medication isn't worth it to them. But yet when you talk about metrics, they're black and white. So understanding how the metrics fit with what the patients really want is another thing certainly that this group could look at. Just putting up the three areas that I discussed there. So, well, thank you, and I think we'll open things up now as a panel, and hopefully someone will guide me on how much time we have. Okay, so, is this working? So I'm told we have 10 minutes, so be happy to take any questions, and you can address them to all of us or one of us, whatever you see fit.
I'm giving out magic wands this afternoon, so each one of you get one. What one thing would you do to get patients more engaged in their self-management?
Do you want to start with that, Irma? Well, you're a patient. You obviously got very engaged. So
Yeah.
what could people do to get...
Well,
Or what worked for you then?
what worked for me was like one-on-one. Yeah, her being there for me, monitoring me. That's what worked for me, and I think that's what's needed more, because like other people have said, you can give people the information, but if you're not there for them, they're just going to put it aside. And that's what I did in the beginning until I had them come to me and say, we're there for you. Excuse me?
Did they keep you accountable? Did that person keep you accountable, or was it just more encouragement?
The first one or the clinic?
The clinic.
Oh, they were there for me. I mean, it's
Okay.
one-on-one. It's not like here,
Did
take
you
this.
reach out to them, or did they reach out to you?
They reached out to me because
Yeah.
they figured,
Okay.
okay, can we get you signed up for this? And I thought, oh, yeah.
So then that did keep you accountable then?
Yes.
Okay,
Yes.
okay.
Sorry.
Okay.
Did you want to...
I guess my wish would just be for me and my staff to have more time just to be able to be with the patient one-on-one. I get so sidetracked, as you could tell from my rant up there, was doing all these other tasks when these things should kind of be happening automatically. I'd rather be able to talk specifically what is going on in the patient's life, what's happened in between our visits, or what can we be doing better in between. As I've started to ask that more and just take the time for that, I've gotten some pretty surprising answers and some better results. And again, that's been with the help of the RN care coordinators as they've taken their approach to it. It's opened my eyes up a lot. And so I think more of that and having the time to do what I think we do best or haven't done best up till this point.
But that engages outcome better because of more time with you? Patient outcome?
I don't know.
Patient outcome is better because of you're spending more time with the patient?
I don't know if it has to be specifically with me. I'm biased towards myself, but at least with our staff, and the frustration I hear from patients is they either want to talk to me or my nurse, very often too, and if they're rather than talking to not a random person, but any other person at our clinic. I mean, we're trying to build team-based care, but we're also realizing from the patient perspective, they don't want 10 people to talk to, they want 1 or 2 people to talk to. Even I'll often get messages to say, well, this person recommended this, or the diabetic educator recommended this. What does Dr. Hawkins think about it? And of course, they're using evidence-based medicine, and I'm going to agree with that, but they also just like to hear that too, and I hope that will have a positive effect because I've taken care of them. I've taken care of their kids, their parents, and I think just more accessible that way, which I think we've put up walls that hasn't always made that possible.
Okay. I'm already loud, but speaking from that experience and as a new care coordinator myself from within the organization and some of the thinking of team-based care, I see kind of a huge area of research in the collaboration with care coordinators and patient quality of life by using that new role and all the different areas where that care coordinator role, or whether it be a health coach or what other organizations, might call it. I think there's huge opportunities for research and improvement of with having the patient on board. I guess that's not really a question, but.
I agree.
Yeah, that's an easy one. I think we can all we can all agree with that. And it is, but I think it's more than just should you do it. It's figuring out what is the right way to do it. What is the right person in that position. So there are lots of opportunities for research around it. Even, once we figured out overall, well, this seems to work. That's not enough. We need to figure out, more precisely how it can work. And it'll vary by clinic. So some of this will need to be done individually in clinics too. It doesn't have to be some giant research study to figure out what works better in each individual clinic, but at least to give you some tools that you can try in your clinic. So tools that we know work, I think would be useful.
And with that, I always think of the comment or cliche of, everyone working to the top of their degree. It's a nice saying, but I don't see it happening. Again, as I sit at my desk or I see what the RNs do or the MAs, and it's that's where there's many opportunities in that area for sure. Cindy?
Yeah, hi. I'm Cindy Huber with the National Kidney Foundation of Wisconsin, and I've had the privilege of working with most of our panelists, who are awesome, by the way. But I think we want to I think it speaks to the last speaker's comment, was Rosa and I, our organization, we were all part of a project in Waukesha County, but it was really, I think what John has just been speaking to also, was really a coordinated effort in terms of the medical resources within the community, but also the community resources in the community, but it also integrated a lot of lifestyle related resources in the community. So meal sites within the community, food banks, etc. But I think our biggest point and our learning was over a 2-year period, and the outcomes that we had for individuals living with diabetes was that first conversations have to start in terms of awareness. And Dr. Hawkins, I just remember that when we started our work together, you made a comment to me that was pretty impactful. A person like Dr. Hawkins and many of you have to know about a lot of stuff, and the stuff you have to know about and call upon changes with the different person that is in your office, etc. And I think just even having an opportunity to go back and revisit some of the CKD things when we went to the spring clinical meetings and some of the work, just to kind of raise that back up. I think it's difficult in terms of the clinic, but I think the conversations are important, and just it doesn't always require a lot of money, but I think the biggest thing was the conversations and how care was happening even within a community. And I don't know, Rosa, if you want to comment. And I don't know if you have any comments about that, Dr. Hawkins, but his team worked amazingly hard to look at the patient first, and I think, but it was the time and some of the process challenges that you talked about.
Yeah, I think your point just being of how can we efficiently use the time that we have, and again, another big area for opportunity, which again can be done at the clinic level in many ways, not just for chronic kidney disease, but I think it's a good framework to use though. And that's what we learned as we went through the process at our clinic.
It's curious to me that when you were talking about presenting the risk to patients, that one of the major diseases that we have, diabetes, has got this term called pre-diabetes, which for you, Irma, meant I don't have it yet. And yet that in and of itself is its own condition, and whether or not we just even sometimes give a different terminology to that. And if you had been told that you were insulin resistant, which means you've got something, would that motivate patients to become involved in their self-care sooner by presenting the risk more accurately than our euphemisms of low risk or pre-diabetes or almost hypertensive or whatever it might be that we slide into.
I don't know if I can answer that in the right way in my own language, but not in Spanish though. But yeah, I was really I don't know if I understood that very well, but when I joined that pre-diabetes clinic, because the doctor told me I was a pre-diabetic, and before I joined the St. Joe's Free Clinic, and then it came to be real the second time. So when they told me that, you know, I had to do something about it because my points were up there, and to them I'd be a diabetic. You know, so when they say pre-diabetic, to me it's like, you know, I'm not diabetic yet. But it's real. It is real. You know, even though they say it's pre-diabetic, they're actually saying you're a diabetic, and you need to do something about it. I don't know if that answered your question or not.
We're going to have to stop now due to time, and we'll reconvene in 10 minutes at 3 o'clock. Let's thank the panel.